I think I must thank Malika for giving me this opportunity, but it's, and it's really very difficult to, put everything together in 7 minutes, but I'll try my best. Basically, I'll be talking about, the topic is macula in branch vein occlusion, so I didn't know, what exactly she wants, but nevertheless, I thought it is better to update you about the different modalities of treatment in branch vein occlusion. Not branch vein, but venous occlusion for that matter. I have no financial interest to be disclosed, and we all know that the majority of the vein occlusions are the branch vein occlusions, and one of the major cause of visual loss is macular edema. And with macular edema, we have a whole lot of events starting from the compression on the vein, and then the blood flow turbulence is there, and then there is a pressure, and then there is a non-perfusion, and there's a hypoxia and VEGF, and then the macular edema. This we all know. The treatment options we have, earlier we used to have the natural history. We'll wait for 1/3 of the cases, they used to dissolve on their own. Laser has been tried in branch vein occlusion. Intravitreal steroids have been also tried. Steroid implants now being tried very frequently, and some of us are also using as a primary mode of treatment. Anti-VEGF, of course, is everywhere, as just now we had heard in AMD and other diseases. And then combination therapy is something, which needs to be relooked. The main problem of the lasers were that there was a damage to the photoreceptors, there was a decrease in the visual acuity, and also for cases where there was subfoveal macular edema because of branch vein occlusion, in these cases it was very difficult to do the lasers, and therefore this emergence of alternate mode of therapies, intravitreal steroids, you have so many trials are there, and we have fanciful names from coming from the clinical trials, like SCORE trial, which tells you that if you use between 1 milligram and 4 milligram steroids in cases of branch vein occlusion, you find the vision gain of 26% to 27% versus 29% as far as laser is concerned at 1 year. However, there was a significant cataract and rise in the intraocular pressure, and therefore this treatment is not very well accepted. And again, for CRBO, for the same thing, there was a higher chance of cataract and intraocular pressure rise, and therefore not first line of treatment. If you see these steroid implants, which have been very often talked about, and we have been laying our hands on these steroid implants, you find that the vision gain in 0.35 and 0.7 milligram, especially in cases of BRVO, is 26% to 30% versus the sham. And in this particular case, we don't have the problem of cataract and the intraocular pressure rise, and therefore whatever rise is there is manageable, could be tried as a first line of management. And then central retinal vein occlusion, again, this 0.3 milligram is better than 0.7 milligram, and the concern for the cataract and intraocular pressure is not there. That can be managed and perhaps could be used as a line of treatment. Now, anti-VEGF in retinal vein occlusion, these have been changed the whole concept of management of retinal vein occlusion, and we know that the benchmark in this particular area is the Bravo study and the Cruise study. And the Bravo study says that 0.3 milligram or 0.5 milligram versus sham, we find that the 0.3 milligram is better, and where 0.5 milligram, 61% or 55%, and there are no side effects, and therefore this could be recommended as the first line of treatment. And then we have Cruise study for central retinal vein occlusion, and we say that 0.3 versus 0.5, again, hardly any difference between the two, and at 6 months, and there are no side effects. It could be one of the modality of treatment for this retinal vein occlusion and central retinal vein occlusion. If you see this branch vein occlusion, this is an idea, and which is recently, I don't think it is available in India. and still not marketed here. 2 milligram was 4 weekly versus standard care, and you find there's a gain of 53% versus 27% at 6 months and no side effects. And this also qualifies to be, in the line of first line of treatment for retinal vein occlusion, and perhaps the same thing for central retinal vein occlusion also, then could be perhaps recommended for first line of treatment. So you have a lot of alternatives, lot of things available with us. The main concern is that the multiple injections have been recommended in Bravo study, and we have to understand the branch vein occlusion especially. It is not a diabetic retinopathy or AMD, it's not a chronic disease. What is branch vein occlusion? It is an acute process, and this is an intraretinal disease. Branch vein occlusion is more forgiving and it is less demanding for multiple injections. So that we have to keep in mind. So we did a small study, and we were trying to look for an efficacious, economical, sustainable and acceptable management of branch vein occlusion, where we also took into consideration the compliance of our, that's the Asian countries, and also the cost factor which is involved in this. And what we did was this is the study. You can see the 4 arms are there. What I have done is, because of paucity of time, I am not talking the entire study, but what I am saying here is that we superimpose our study, although the study protocol were not same, nevertheless the end point of the result that I am trying to show you here. As you can see here, the top one is the one with the laser with Lucentis, which means after one Lucentis, we get the laser and we follow this patient's PRN. And the other one is laser plus loading, which means 3 loading dose of anti-VEGF, especially Lucentis we had given, and then after first injection we did the laser, and then 2 more Lucentis, and then we did the PRN. And if you see here the Bravo and the sham, in the Bravo study Lucentis and sham, you find that the results were much better in these 2 groups, where laser loading means 3 Lucentis and 1 laser was done, and then the other group where 1 Lucentis was given and laser and followed PRN. So that's what we want to show you here. Another study we did, we compared the Avastin with the this is the mean change from baseline. Oh, this is the central foveal thickness, what I am talking here. And again, in central foveal thickness also we found that the results were better when we give 1 injection plus laser, or 3 injections plus laser, rather than giving monthly injections of Lucentis. And this is the economics. I will not go into the detail now with the Lucentis coming, bringing the price down. Of course, this has gone much less, but nevertheless, still, look, Avastin, is less costly as compared to the Lucentis. And also, Bravo study will cost you more as compared to what the study we did. This other study we did between ranibizumab and bevacizumab. As you find here, the 2-line and 3-line improvement was not much difference between the ranibizumab and the bevacizumab. Of course, little bit edge of Lucentis as far as the 2 modalities are concerned. If you see here, if you see the summary, BRVO, in BRVO, laser, steroid, anti-VEGF, steroid implant, and this idea, you find that anti-VEGF has definitely better than compared to others. Visual benefit, in terms of visual benefit. And in CRVO also, you find here that the anti-VEGF is scores very close to this idea, which is 55 to 60%. So they are almost, competing with each other. So my take will be, first line is anti-VEGF or a steroid implant. Alternate will be steroid implant. Combination therapy is efficacious, economical, sustainable and acceptable. As I told you, that you give 1 injection, especially for retinal vein, this branch vein occlusion. You give 1 injection of Lucentis and then do the laser and follow it PRN. So that is, that can be tried. And of course, laser and intravitreal tamoxifen alone has minimum or very little role to play in retinal vein occlusion. I think that was the last slide. Thank you very much.